Great. We're going to go ahead and get started. We have Dr. Robert Smith is our convener here today, and he is virtually online. And why can nobody see him? Just a moment. We're going to alter what's being shared here.
Can you hear me, Keren?
I can. What we're going to try and do is get everyone to see you.
Okay.
My
laptop.
Oh. All right, we can see you, Dr. Smith.
All right. This is scary. I'm looking at myself here. All right. Welcome, everybody. I'm greeting you from beautiful Ohio, Kettering, Ohio, where it's in the 70s. The smell of lilacs are in the air, the beautiful blooms of all the tulips. So with a little sneak preview, Keren and I are arranging for you all to join us next year, if everything works out in beautiful Kettering here. So I am so honored to introduce our speakers today. This is let me make sure we get the title right. I think you had it up there earlier. We're looking at leading an ethics program across a large health system. And with pleasure, I introduce our two speakers today. Alan Murphy is the Bioethics Director for Kaiser Permanente in Baldwin Park Medical Center, not far from Loma Linda, LA County. Prior to that, he was the System Director of Clinical Ethics at Ohio Health. You'll see a common theme here in a minute. And he was the Vice President of the Bioethics Network of Ohio and advised the Ohio Health Department during its review of the state's do not resuscitate laws. So Dr. Murphy's had much experience. He earned his master's degree from Yale and his PhD from Vanderbilt. Welcome, Dr. Murphy. Dr. Keren Tanguay, my great associate from Kettering, is an assistant professor of religion and bioethics at Kettering College, but also our director of clinical ethics in Kettering Health, the entire network. She has her master's from Fuller Theological Seminary and a doctorate from the Ohio State University. You have to have the. And she previously had been Ohio Health, where they were good compatriots and continued to serve together on the Bioethics Network of Ohio. Both of our colleagues are healthcare ethics consultants. I've been very honored to work with Keren over the last year as we've looked within our own network, campus by campus, to develop systemness across ethics and to handle the questions that, a small hospital may not have a full committee, but how do they get their questions answered? Larger hospitals would have full committees. But how do we really have consistent answers? So again, with great pleasure from Ohio, I will turn it over to Keren and Alan.
Thank you, Dr. Smith. So without further ado, we'll go ahead and get started with our beautiful. So we're talking about building and leading an ethics program across, I feel like I can't see you guys. So building and leading an ethics program across a healthcare system. And as we were trying to conceptualize how we were going to frame this topic that could very easily be a conference in itself, we were thinking about what came to mind was the story of Nehemiah, right? Which is it's a very short chapter, short book in scripture, but I think the lessons that we glean from sort of the strategies that he put in place to implement such an important build and innovative process, right, that was important for the people of Israel is something we can really tap into as we're thinking about building and leading an ethics program across the healthcare system. So for our objectives today, we're going to be identifying components of an ethics program and strategies for implementation, assessing necessary qualities and skills of ethical leadership in building a program, and describing the value of an ethics program for healthcare systems. Why is this important? So I invite you to take out your phones. There's going to be a lot of engagement during our time today. It is a little less now than a 2-hour session. So we really want to be talking with you guys and getting your thoughts on things. So tell us a little bit about yourself. I've got a survey up here. That's a QR code, hopefully, that your phone will read. If it can't, you can always go to www.menti.com and just enter that code. That should bring up the survey. So we would love to just know a little bit about you, sort of your context and where you're coming from, so that we can really glean from your context as well as we're talking today. Okay, beautiful. Let's see the results. Okay. Oh, this is really, really useful. So it looks like a lot of leadership and administrators here in the room, as well as some chaplains and clinical physicians and ethicists as well. So certainly all stakeholders to this conversation. And we asked if currently working in a hospital that has an ethics program. Looks like most of you are. Significant number there, 16. I'm glad. I mean, I think it would have been great if someone said, "What's an ethics program anyway?" but no takers there. In terms of being part of a hospital ethics committee, many of you are part of an ethics committee, which is really helpful for us to know. And there's certainly some interest as well of those that aren't on an ethics committee, but certainly are aware of their hospital ethics committees. And then conducting ethics consults, pretty split group more or less here. Looks like many of you are conducting ethics consults as part of your work in the hospital, doing some work, and some of you are not presently doing ethics consults as part of your day-to-day job. I think that was our last question. Nope, I lied. One more question. Charting ethics notes as part of your consultation process. So it looks like a majority of people are not consulting. Not putting chart notes. So we're going to talk about that today. Chart notes in the medical record, but many of you are. So those are some great numbers for us to be aware of as we're going through this content. So we're using the Nehemiah as a frame of reference for thinking about implementations of building a program and leadership in that implementation. And when you're starting a new process, like building a wall, right, around the city, or building a program at a hospital system, there's all these questions that you start needing to brainstorm, right? Like, what does an ethics program even entail? What are the components of an ethics program? What does an established ethics program set out to do? Do you need to have like your own separate vision or goal or mission statement? And how does that necessarily relate to the overall organizational program and mission and values? So these are questions that we hope to create some potential answers to. We're certain everybody's context is a little differently. So we're hoping to sort of just create material that will give you the tools to formulate that kind of an answer. But we would love to know from you what you think an ethics program is. Like, when you think of an ethics program, what comes to mind? So we're going to do the keyword. We had some ambitious answers here, and see what kind of words or phrasing or maybe particular operational things you think an ethics program should have. What just comes to mind? There's no wrong answer. What comes to mind when an ethics program, the phrase, is mentioned? All right, let's pull up those answers. All right. So, interesting. So some things that stand out to this group when thinking about an ethics program, policies, the way that a word cloud, are you guys familiar with a word cloud? Okay, because I was explaining this to him when we were practicing it, and he was like, "I know what a word cloud is," so I don't want to repeat this. But it looks like justice and policies as being put in the center is maybe something that came up more than one time. So that's a common theme or thread that's being pulled out here. We've got things like training, quality, integrity, mission driven, helping people policy in a variety of different forms being captured there. Education is certainly a theme that's been like between training and education. There's some parallels. Interpretation of law, consults for family meetings, protection. That's an interesting one. Integrated. We're going to talk a little bit about what does that look like? What does it mean to have an integrated ethics program? Shoestring. That one might need a little explaining for me. But oh, okay. Got it. Okay, that makes sense. That makes sense. Protected time. So these are some of the things. Some of them, as we can see, some of them are a little bit more like operational pieces that you would need to implement, like tangible workload kind of things. And some of them are more kind of ethereal philosophies, right, of how a program should carry itself, which is part of the dualities we're going to work through today. So let's go back. Okay, so thinking about what it's like to build a program, right? Kind of like the wall. We're thinking of organizational ethics as sort of the foundation. Another way of thinking of this is an umbrella kind of metaphor. And there's so many different pieces of an organizational ethics program that you might want to create, right, to build this out. And I think when we're thinking about laying bricks or laying stones, probably stones back then, this question of what is more foundational, like what should be closer to the bottom than to the top? What are things you need to do first before building on that? So we have some pieces of potential operational pieces to building an ethics program, but this is going to be a question that you have to ask yourself at each of your care sites or your systems, right? Like what is most important? I think we could probably sit here and discuss and maybe disagree or think differently, right? About which blocks here should this be further down? Should this be higher up, right? Like that kind of an order of what feels more foundational. And if there's things here that we haven't included that should be part of building an organizational ethics program. And we often think about like the difference between some of that sort of bedside work and then an overarching program. So this is out of an article called Developing a Clinical Organizational Ethics Program that I recommend and is good to read, just sort of thought-provoking. And they created this table that I think is useful to just see that there are some distinctions, but they're certainly compatible, right? There's overlap in this work. And the other article that we're going to discuss today sort of talks about building an organizational ethics program out of a clinical ethics service, because it does so in a more organic way. And one of the ways to sort of illustrate that is this like top piece, right? Where an ethics consult might be more individual patient-based, right? At bedside, there's a particular dilemma we're dealing with, but maybe several of those kinds of consult might show a pattern, might show a theme that needs to be dealt with at an organizational level, right? At a system level. And that's where you see programs sort of grow organically because they're coming from the bedside. There's already a lot of people invested in making sure that this kind of systemness works because they see how it impacts patient care. So I think that's really useful because it prevents, I often feel like in building a program at Kettering Health, the way that we are right now, a little bit like a salesperson, like always pitching to administrators and leaders and stakeholders like, hey, this is something we should be doing more of. But when it's going on at the clinical setting and there's lots of people that are seeing how this is unfolding, it's a lot easier to show, right? Like the work that we do and why it matters. So healthcare ethics committees, we don't have time to go through every one of those blocks, right? And this is probably the one that everyone is most familiar with because as the survey showed, many of you are involved in this kind of work. But we're just going to briefly touch on ethics committees as part of an organizational ethics program. We would love to know a little bit about your ethics committee and what kind of work they do. So new code on menti.com, or you can just use the QR code. Let's pull up those answers. Okay. Oh, wow. So three very clear themes here that everyone is saying. policy education consults. And there's some sort of maybe smaller outliers like legal backing and finding next of kin. We're like, who is that? We'll put that in there. You didn't know this was a confessional time, no? Advices on cases. There's definitely some themes here with conflict resolution. But it does look like there's a lot of consultative work coming out of the ethics committees that you guys are a part of, which is good to know. And not true of every ethics committee, right? Not every ethics committee is working through live consults. I think there's one more question. Yeah, so exactly what we thought based on the word cloud. So a lot of your ethics committees are working on live time acute consults, and not necessarily just working through the patterns of consults and retrospective review, which is really interesting. Okay. So this number, as Alan points out, as he was looking at my next slide, is larger now because this is actually a fairly older study. But at the time, which was, I think, 2007 when this was done, it's estimated that over 30,000 people in the United States currently serve in a healthcare ethics committee of some sort. That's probably doubled by now, if not more. So even back then, right, that was quite a bit. And then what are we thinking about a healthcare ethics committee? What do we think, they can be a part of? We talked a little bit about all of that in the word cloud. Developing policies and education was certainly at the forefront of the answers that we got here today. And then consultative work. Within that consultative work, we're looking at sort of the ability of committees to offer conflict resolution and reconciling sort of obligations that are maybe competing at the organizational level, but also at bedside, clarifying terms that we hear all the time at bedside, right? Like futility, goals of care, what does comfort care mean? And then diffusing that tension that can happen both between families. Yes. Yeah, absolutely. Absolutely. Which is why I think that pattern of being able to see certain consults come through and you're seeing a pattern of this is an issue. Let's do some preventative work to keep this from being an issue is absolutely, I think, one of the ways that we marry, right, that consultative work with organizational ethics. Because that would take collaborative work with other stakeholders, right, when we're talking about like implementing more advanced directive processes, for sure. So these are just some consultative models, right? And I wish I had a survey of this. Maybe we'll just do a raise of hands of how consults are dealt with, right? They might be dealt with as a full committee, which is great because it's multidisciplinary, but there's some pros and cons to that as well. As an individual consultant, which is more popular, I think, and more common in larger healthcare systems that have the funds to do partial FTEs or full FTEs doing consultative work. And then consultation subcommittees, like a more triage groups, maybe within a healthcare ethics committee that deals with the live consult. How many of you here does your ethics committee do like full committee consultative work? It depends. What does it depend on usually? Availability, like how the case. Okay. Okay, so how far along they've gone trying to work through the process before we gather everyone. Okay, yeah. So certainly I think that there's not necessarily a right or wrong answer here. And I know that even at my hospital system now, there's different hospitals that use different models, right? Depending on how small the hospital is or how many consults they get, what they're accustomed to culturally. We have some hospitals that do individual consultants. We have some hospitals that have it like a small group of 3 to 4 that are trained to do the consultation between their ethics committee. And then other times when we have a consult, everybody's getting there. The CMO is on board, the director of nursing is on there, and it's like all these administrators are dealing with the consult, right? Which is really foreign to me from where I came from at Ohio Health. That wasn't our model of consultations work. So that's something I'm getting used to.
Before we move
hiding behind the projector. Before we move on, how many of you all, let's just round this out. So there's sometimes for the full ethics committee, how many of you all send one person from your ethics committee or a bioethicist to respond to consults? All right. So how many of you all, when you have an ethics consult, send one individual person from your ethics committee to handle that consult? See one hand in the back. Sometimes, I think, probably. And then, all right, we have a few more hands over here. Fantastic. I'm just trying, this is basically my roundabout way of trying to ferret out the ethicists from the initial survey response, so I know who to look out for. No, I jest. And then how many of you all, now I figured out how close to hold it. All right. How many of you all have when there's an ethics consult, you have a specific defined subgroup within your ethics committee who handles ethics consults? I would have been, yeah, like some ethics committees will have like I don't know what you all call yours, right? But we'll have the consult subgroup, right, or or the triage team or something like that actually handles consults that come up, and with the result that other members of the ethics committee may never actually have a hand in working ethics consults as they unfold. So we have a pretty good split. And that's not surprising to me. The only thing that actually surprises me is that we have so many people who actually use the individual consultant model in the room, which is great. All jokes aside about looking out for you all. It's great that we do, right? But that's actually pretty unusual nationwide based on the last round of surveys. It's much more common. Fox and colleagues have found at academic medical centers and very large systems, much less common everywhere else. Right. Well, thank you for that. That helps us. All these questions are going toward helping us make sure that this is a presentation that we intend to evolve, and we based on who we actually have here. And it's also one that we hope ultimately we can all learn from one another, because I think one of the big things that we're going to draw out, and it's been drawn out a number of times about our field, is that one of the things that prevents us from all making progress is that we don't actually compare notes. Right. We don't actually talk with one another in a robust way like you all are doing here, which is fantastic. Right. But we don't actually talk amongst ourselves, even within the same organization. Individual ethics committees don't always talk with one another in a way that allows them to learn from one another and to grow. And as Keren and I will have a fair bit of opportunity to say, that is one of the key steps in being able to move from an ethics committee towards a more clinical organizational ethics approach.
So we're going to talk a little bit about organizational ethics near the end of the presentation, but just to touch on sort of the role of healthcare ethics committee within sort of this organizational function, there's this phrase, right? Ethics is everyone's business, which in general is true, right? But I think what the challenge with this phrase is that it doesn't actually tell us how that translates into workflows and processes of whose hands are on deck when we've got sort of issues that we need to work through, like things like advanced directive implementations, or we're changing policies around code status, right? And there's certainly overlaps, right, of other stakeholders across hospital systems that are doing things that have overlap with healthcare ethics committees' priorities, right? Like chief executive officers, medical executive committees, the IRBs, and none of them have the term ethics, right, in their committee, but they also have some priorities that overlap with the priorities of ethics committees. And I think that when we consider sort of the marriage of clinical ethics consultative work and organizational ethics, it's not necessarily that they're two separate things. It's more of a shift in perspective. So we're going from symptom management to really holistic health. We're going from thinking about just this particular patient and how we navigate this complexity to what are the possible structural causes of this obstacle that we're seeing translate in this particular bedside case. And the context, of course, of how ethics committees, in which ethics committees live right now, right? This is the cultural context of our providers every day. They may not say these exact words, but I've had lots of conversations with clinicians that more or less amounts to this, right? The pressures that they're feeling to improve the quality of care, no matter the cost, but also reduce the cost, no matter the effects it has on patient care, and the old age sort of confliction of evidence-based care versus patient preferences and how to work through those. So we wanted to do an ethics case and have you guys divide into your own ethics committees. So maybe, how many are we here? Yeah. We will be circling back afterwards.
But one of the things that I think hope will be helpful to you all, right, is precisely, thank you. This way I can tell the people online something that is no application to them whatsoever. We apologize. You can imagine yourself surrounded by a cloud of your peers. But for those here in the room, what we hope to do in part by this, at this case, is actually get you all talking across organizations about how you would handle a case like this specifically. Right. It's easy enough to talk about, oh, yes, these are the, the common heartaches and headaches of healthcare ethics consultation. It's another thing to actually compare notes about how your committee would actually handle a specific case, which I think I hope will have the ring of truth for all of you. For those in the room, we're passing out a document that details the case somewhat more so than is on the slide.
So we'll let you guys read this, but just the gist of the case, you have the particulars in front of you. This is a 31-year-old. For our purposes, we're going to call him. Oh, what is this popping up? Oh, for our purposes, we're calling him Mr. Ramirez, and he was admitted to the hospital following a trauma. He sustained multiple injuries, resulting in the patient being intubated. He's now been with us for 3 months in the hospital after being intubated, and he is been dependent on maximum oxygen settings and also has a PEG in place. His patient and family are from Bolivia. He has 4 brothers and a mother who have been involved in family meetings with us. And the challenge is he's no longer inpatient appropriate. So there's some complex disposition going on with lack of pace source and yet the need of high intensity medical interventions if we're going to proceed with full interventions. And when we've talked with the family, they've said that unless neurology can say with complete certainty, 100%, that there will never be a recovery for this patient, for their son, for their brother, they're unwilling to stop high intensity life support. So probably things we're all familiar with and have heard in some case or another. So dilemma is, right, ICU is uncomfortable with continuing treatment. They will, throwing around the word, medical futility. This is not appropriate anymore. There's certainly some reason for distress around this, right? ICU bed shortages, chronic condition that no longer requires acute level care. And then we're thinking here, like other priorities that have come up in conversations of like ceasing hospital reimbursements because there's not a pay source in the state of emergency fund. We'll stop reimbursing the hospital once it's no longer medically appropriate. Other things thrown around in conversations with staff have been medical repatriation. Is that something that we're willing to do? Think is ethical? Should we do? And then also thinking about if they can't pay for care, do we do charity care for long-term care facility? For how long do we do that? And then if we stop, what happens to the patient? Okay. So in terms of steps, we're hoping to get from each of your groups, determine next steps as the first one, and then develop recommendation following that, and then draft a chart documentation.
I think so. In terms of making sure this is as good as we stay on track, more or less on track for time and everything else. And also to make sure that if people end up having the same questions, that we give everybody the same answers, right? What I think I'd like to do, what we should do here is let's take 5 minutes amongst yourselves, decide what your next steps would be, right? What additional information would you want if it were available, right? Who would you talk to? What would be the purpose of that conversation, right? What would you be going in trying to accomplish? And any other essentially information gathering steps that you'd want to take. We'll take 5 minutes amongst yourselves, decide what those steps would be. We'll come back together as a group here in the room, answer all those questions together. Ideally, some people will have the same questions and we can answer them together, right? And then we'll move on to the next step of trying to develop a recommendation and fleshing that out in a chart note for the sake of argument. So let's take 5 minutes amongst yourselves and decide what your next steps would be in terms of information gathering. Yeah. As of right now, it's a great question. As of right now, none of the family lives in Bolivia. The patient's brothers are all already in the country. The patient's mother came up on a visa after he was seriously injured to be at bedside, and as you'll note in the case write-up, although it's scarcely clinically relevant, the patient from an insurance standpoint is an undocumented immigrant and will never qualify for healthcare insurance.
Okay, so let's go ahead and circle back for the first step of determining next steps. You'll want to stay in your groups because you'll have 2 more things to discuss with them. But for next steps, what did you guys come up with? What questions do you guys have that you'd want to ask other stakeholders? What were the thoughts? Yes. Okay, so assessing values in a family meeting. By the time you get this consult, right, there's been like 5 family meetings. Just so you know. I don't know if that was in the write-up or not. We're just gonna play ad lib here. Okay. Yeah, so good.
If it hadn't happened already, had it not already happened, that would be, of course, I think we all, I hope, agree the right next step. If we hadn't actually bothered to suss out this family's values, and more importantly, from our standpoint, perhaps what the patient himself would have valued, as you said, right, then that would need to happen. Let's say go ahead. Right.
We'd have to find a provider that would be willing to say with total certainty, right? Because that was part of the write-up, I think, was that the family needed to hear 100% there is no recovery from this, which a lot of providers don't want to say, right? Especially with brain injury, because it's so unpredictable. It could take months to see the, smallest of progress. Go ahead. Sure. So maybe asking the family, when you say, will this patient recover? Will my son recover? What does recovery look like to you? Right. Other groups. Yeah. So the state emergency fund only applies to acute admission. Yeah. Which is that under, I don't know, is it under Medicaid? It's like one of the, I think it's, yeah.
I apologize to folks online again. We have just the one mic. They'll forgive us someday. But all right. Yes. So is it even long? All right. There we go. I'll just smack it right up against my mask here. In LA County, for example, in LA County, but only in LA County, healthcare workers still have to wear masks in clinical settings. So force of habit dies hard. Also, I'm going to my parents' 50th wedding anniversary next week, and I don't want to be sick for that. So in any case, I hope you'll excuse the incivility, as the case may be. But I digress. A lot of this is going to hinge pretty dramatically by jurisdiction here. But yes, we'll say for the sake of argument, in this particular case, I hear what you're saying. I think it's a great question, which is, at a minimum, right, what will insurance actually cover, right? How far can we, that is something we need to get clear on, right? And we will supply, once we get all these questions aggregated, Keren and I will make up absolutely definitive answers for you for the purposes of this consult here. Couple more questions.
Great point. Yeah. And one of the challenges, right, of ethics cases with any kind of, oh, okay. We're bouncing, we're doing a dance here. One of the challenges of ethics cases that we confront, right, is the turnover of providers, right? And how many different providers have been in front of that family, maybe not more or less giving the same message, which is hard to know when you're getting into a case at, 3 months in, what's happened for the last 3 months. So I guess in terms of steps, the first recommendation was a family meeting. Was there another step that anybody got further down? Oh, the asking for the insurance.
Don't mind. Yeah, so I think I've tried to take some notes here just to try and organize things. Yes, beautiful. Yeah, I'm getting a thumbs up from the window. Yes, I always take the encouragement. So I think it's very reasonable, right, to say clear on what exactly are the medical facts, right? I think that's always prudent, right? I think it's one of the first things we're taught to do as ethics consultants. And let's say, for the sake of argument, in this case, in addition to what you saw in this case, that neurology has run all the tests that are available at the hospital where this patient is hospitalized. Neither neurology nor anybody else is recommending transfer to another hospital for further workup, and he's where he's at, right? Neurology doesn't see any reason to believe that he is going to improve, but the neurologists, all three of them who round at the hospital, not a single one of them. I apologize. Any neurologists in the room? Okay, great. No, I love neurology. I really do. Yeah, as you all are well aware, neurology and clinical ethics have a lot of structural affinities in living in the world of ambiguity, in a good way. But true to form, neurology is unprepared to say that he will never recover any function at all. They think it's vanishingly unlikely. To your point, several of you made, it's vanishingly unlikely that he will enjoy anything that would allow him to ever live independently again. But they're unprepared to say that he will never recover awareness. Right now, he's meant, as you saw in the write-up, right? He's unaware, right? He breathes over the vent, and that's what he's got. Right, but they're not prepared to say that he won't improve, that he will never recover awareness above and beyond that. But they are prepared to say that he is very likely, almost certain, essentially, to require care in a licensed facility, something like an LTAC, for the rest of his natural life or unnatural life, depending on your point of view at this point. What has the family heard? Fantastic question. Let's say, for the sake of argument in this case, that because I hope this case has the ring of truth to all of you, right? Because probably you can't kick around too long without bumping across cases like this. What has the family heard? The family has heard exactly what you say, which is that he's imminently dying, and he made it, right? And he was imminently dying again. But when he was imminently dying, when he tanked on arrival, he survived the night. He's a young guy, or so I tell myself, because if he's old, then I am too. He's a young guy. They've been told many times that he's tanking, and he's not going to make it through the night, through the weekend, through whatever else. He's done it every time. He just hasn't improved. Right, he's in a very he's what a lot of people in the literature you all have seen, the same as I am, characterized as chronically critically ill. This is how he is. This is how he is. They've heard many times that he's going to die, and he is not. In terms of I think the next step that you all suggested, right, was a family meeting, and I think that's very reasonable if it had not already been done, or even if it had been done. To your point about an ethics family meeting. How many of y'all, in a case like this, by policy or by standard practice at your organizations, require ethics consultants specifically to have a family meeting, irrespective of how many family meetings have already been done? Out of curiosity. Strongly encouraged, but not required. Yeah, it's probably good practice. I'm hearing probably good practice. I would be disposed to agree with things like that as well, right? And let's suppose, for the sake of this case, that even with that information clarified, that the fact of the matter is that the family, if there's any prospect at all, however slight, that the family believes that what this patient would want was every chance to recover, every chance, no matter what recovery looked like, no matter how slight it was, he would want every chance to recover, even a little bit of function, so that he could be aware of his family.
And the reason behind that you discover in your first meeting, let's say, for the purposes of formulating a recommendation next, is that they had another brother that had a very serious incident and was told, you're never going to walk again. You're never, going to get off the vent. And lo and behold, he's walking. He's got a cane, but he's walking and he's breathing. Yes. And everything would be resolved, right? Yes. So that's a great question. And, it's interesting because it came up as sort of the concept of medical repatriation, as we'd say, like, because he's lived in the States since he was like 5. So for all intents and purposes, this is home, right? This is home for him. And there's actually no family in Bolivia. All of his family live here. So there was all these ethical qualms about, where would we even transfer him to in Bolivia? There's no family over there. It's hours away from his hometown anyway, and all of these things. So certainly that was a question that came up. But I think people were really distressed about the idea of sending this man by himself without any family being there and things like that. There's lots of hands populated. Do you have a follow-up? Yeah. Mm. Yes. She asked, for those of you that are online, she asked what we should appropriately be vexed by the concept or thinking of sending him back to Bolivia. But I think the question is, what are we actually asking this family to do? Yeah. Mm-hmm. Mm-hmm. Decision-making choice options. Mm-hmm. So for those of you that are online, if we have people online, I can't tell. The question was, are we really just asking them between two options, right? The option to face certain death in Bolivia or to face certain death here in the US. Is that accurate? Yeah. It was not. It was like phrased, and they had like a very extreme reaction to it. Like, absolutely not, right? This is home. This is yes. Yeah. So for time's sake, we should probably move on to recommendation.
Yeah. Yes. Yeah. So I think these are all excellent points, and to answer to give the ethics committee some context, right? Which I think to your all's point, the ethics committee very reasonably could ask or the ethics consultant very reasonably could ask about the money, right? Right. In terms of this is it is hard, it is uncomfortable, right, for ethics committees to ask about money, right? But the fact is, cases like this hinge a lot of the chat at a minimum, right? We can say that a lot of the chatter in these cases within the healthcare team revolves around money, right? If it cost us nothing and there was no opportunity cost for the bed and there were no expenses in terms of staffing that bed, I don't think people I don't think we would lose much sleep over continuing to care for these patients in our hospitals. Not the matter of sleep that we do in any case. So it's reasonable to ask about the money. We'll bracket the palliative thing and say that yes, palliative was consulted and was promptly fired by the family just for fun. We'll say that as the case may be. And I'm sure it would never happen, but let's say it did in this one case for expedience sake. And in terms of the money, right, what will insurance cover? State-funded insurance will not cover his care outside of the hospital. Full stop. The end. Right. We'll say that in this particular jurisdiction, there's no funding publicly for his long-term care outside of the hospital, and there may soon be no funding internally. Maybe no reimbursement from the state to the hospital for providing his acute level care, as he's no longer, strictly speaking, acute care appropriate. MedFlight, the $20,000 is the best price I've heard, so I may have to ask you. So I may have to ask you who you were dealing with before we leave here today. Let's say, for the sake of argument, that MedFlight is $35,000, right? And let's say for the sake of argument that the finance people tell you somewhat reluctantly, they eventually cough up a number and say that every day he's in the hospital bed without state reimbursement, we are losing as an organization about let's say $1,500 a day. Let's say that for the sake of argument, right? Now, if depending on your organization, your hospitals, and which of the hospitals that we've served we're talking about, that could be high, that could be very low. Let's say it's $1,500 a day for him to sit in that hospital bed once the state stops reimbursing his care, right? So at this point, you've gathered the information that you wanted, right? And the next step that Keren and I have for you at this point is to come up with a recommendation about what would your ethics, having gathered this information, having been consulted on this case, what would your ethics committee actually recommend, if anything? That's the first part of it. This is two forks, right? The second fork of this is, if you document, and we'll say for the sake of argument, at the organization that you're at, ethics does document its advice in the chart, right? What would you document? How would you document your advice, right? It's one thing to actually render your advice to administration and to the consult requesters, be it the attending physician and the rest of the healthcare team. It's another thing to actually put that in the patient's permanent medical record. And I think that's one of the things that we want to make sure to talk about. So let's give them We have until 3:15. Let's give them. We can give them 10 minutes. I think we can do 10 minutes to do both of those things. Decide what you were going to recommend in this case, right, and decide how you were going to document that the patient's chart. And for the sake of time, don't bother writing out your whole chart note if your whole chart note includes a bunch of patient details or whatever else. Just how you would phrase your recommendation in that chart note. 10 minutes. Good luck. Wrap up these intensely abbreviated ethics committee meetings and talk a little bit about what you all had to recommend and how you all went about framing that for documentation. I've lost control of the crowd. This feels suspiciously like an ethics committee meeting, and that we need to move on to the next agenda item, everybody, and everybody's like, no, we don't. But in seriousness, I bet this is going to be interesting, and not because I'll be droning on, but because we're going to compare notes about in a metaphorical and non-metaphorical way. And I hope will be instructive. So we'll start in the back. What did you all decide to recommend on behalf of the ethics committee? And how would you write? Okay, I've got that from my own little notes for my reference there. How would you write that in the chart? Okay, well, yeah, in fairness, I also would spend more than 5 minutes trying to write up a note in a case like this, so it was a little unkind. I'm quick, but not that quick. All right, let's move down to the front. What did you all decide to recommend? Yes, call the chaplains and ask them to pray for us. All right. Okay. I'm not. It's not. I didn't stop taking notes because I wasn't equally interested in that. Quite the opposite. My pen died, which is anyway. That there's something metaphorically apt about that. In this case, I digress. So, if I may summarize, right, the upshot is, on the one hand, in all seriousness, right, if pastoral care hasn't been involved to help this family unpack some of what they're feeling, yes, absolutely. I think that's a reasonable recommendation. And second, right, but in terms of the clinical course, you're recommending a time-limited trial of continued high-intensity life support with the expectation that if no clinical improvement is seen at the end of that time, the hospital ought seriously to consider unilateral withdrawal. Is that fair to say? And how would you write? Did you have any thoughts about how you would document that advice? No? All right. All right. We'll move on to the back. What did you recommend? Yeah. Alas, alack. And I suspect I already know the answer, but any thoughts on how you document that advice? Right on. Okay, that sounds fair to. I mean, I'm not here to critique other things. My point is that what I think is interesting, right, is so far we've had some variation. I'm curious to see what you all recommended. What they said. All right. So, I'm confident that your notes for your remarks don't say what they said, right? So, what did you recommend? All right. Well, thank you. So we'll have a little bit. I think what I want to draw our attention to before I move on to talking about chart notes a little bit, just by way of comparison, by way of spurring some conversation, I hope, among you all, maybe not during our limited time left today together, but during, going forward, right? I think it's interesting that we actually had a fair bit of discrepancy in the advice that was rendered. Now, partly we could, chalk that up to discrepant jurisdictions in which we practice, right? There are jurisdictions in which withdrawal over protest is a manslaughter, right? And there are jurisdictions, thank you. There are jurisdictions also in which there's explicit statutory guidance that allows for healthcare providers to decide that a treatment is no longer medically appropriate or no longer medically effective and ought to be withdrawn, irrespective of what a surrogate would prefer. Right? There's some variation there too. And one of the big questions that I think any of us who've kicked around this field for a while haven't really answered, right? But which honestly, to the point of not even necessarily being popular to talk about, but I think is vitally important to talk about as a field, is, should that trouble us at all, right? That we have, in fact, wildly discrepant advice based on seemingly extra ethical considerations related to legal jurisdiction, and how does that impact our efforts to systematize, especially if you're in a system like mine that practices across state lines, right? And like some of yours may do as well, right? How is it that what's ethical in a hospital in say, I don't know, let's say a hospital that is what's ethical in a hospital in Los Angeles County is wildly inappropriate in a hospital in Atlanta, Georgia, right? That's something that certainly organization is a organizational hurdle that we need to think about, especially if we're systematizing ethics. But even more fundamental, right, which we didn't have much of a chance to talk about. Oh, thank you. Sorry, rather than trip over the stool, I'll just step out of the way here. One of the things that I think actually ethicists paper over, though we don't really talk about as much as we might, and that ethics committees within healthcare systems don't talk about as much as maybe we would like, is how we actually document, right? And I can tell you that if you don't have a standard, right, you're going to get wildly disparate chart notes on behalf of your ethics committee, your ethics committee's system wide, right? These are so this is not necessarily reflective of my practice at Kaiser Permanente in every case or anywhere else that I've been, but these are widely acknowledged, considered things that you might consider putting in an ethics chart note, qua ethics chart note, along the way. There may be reasons that within your organization you don't want to put some of these things in ethics chart notes, or you want to have consistent standards for how you put them in. But if you haven't talked about these things as an ethics committee, right, or if you don't have an ethics apparatus beyond the ethics committee to make decisions about this, ultimately these are things that people might reasonably want to talk about and standardize as well. One thing that I didn't put up on this slide as well, it occurs to me only now, but I think it's as good an opportunity as any to apprise you of. If you haven't decided how you're going to gather information from your ethics chart notes, the sooner you start, the better. And what do I mean by that? Ultimately, because the longer you wait, the harder it is. How many of you are part of an ethics committee that automatically gathers information out of the ethics chart notes it puts in? Because it looks like many of you document. How many of you gather systematized data about the consults you perform? Good. Well, good. I'm happy. I am happy to see that. Right. And ultimately, right. This is not to say that if you don't, you're bad. Right. Far from it. Is 10 years ago when I started out in this field, it was actually like bleeding edge stuff to actually gather automated information out of your chart notes. But nevertheless, it's kind of clinical ethics and healthcare ethics committees are kind of unusual in that we don't, as a matter of standard practice, automatically glom information and categorize our cases that way. In fact, there's no agreed upon way to do that. Next slide, if you don't mind. Right. So what I will say too, because I know from our early poll that we were split about 50-50 in terms of documenting advice in the chart. I can tell you that if for those who haven't seen it, Ellen Fox and her colleagues' poll, the most recent poll that they conducted in 2020 and 2019, 2020, found that it is far more common now for healthcare ethics committees and healthcare ethics consultants to document their advice on cases in the patient's chart than not, at least some cases, right? That's not to say, again, that necessarily anybody's wrong to not do it. In some cases, or wrong necessarily if not to do it at all, if their organizations tell them they cannot. But it is something to consider in terms of systematization. But it does come with some hazards, right? If you're this is something that you can probably tune out real quick if you are part of a group that already does document, unless you just kind of snuck in and are documenting without any kind of review or approval. But if you aren't already documenting, right, and think that it would be beneficial for your patients and for the clinicians caring for them to see a permanent record of your advice in the patient's medical record, it's worth noting there's a lot of programmatic questions that ideally ought to be answered as a system, right, ought to be answered consistently across all of the various hospitals that you serve, rather than handling it on a kind of hodgepodge case-by-case basis, ranging from everything from who actually is going to be allowed to document ethics advice in the chart. Is it any member of the ethics committee who can go in and document on behalf of the ethics committee, right? Or does it have to be somebody specified who's going to do it? How do you agree what's going to be documented on behalf of the ethics committee? Is it somebody who's just taking minutes, or is it somebody who actually hashes out the note and runs it by the whole ethics committee in advance? All the way down to seemingly picky, but rather frequent questions, like what do you do if you have advice the healthcare team is not going to take? right? Do you have an obligation? I'm sure that never happens to you, and it's just a reflection of my deficiencies of character that occasionally I feel obliged to render advice that I know a healthcare provider is not going to take. But if that did ever happen to you, right, what would you do, right? Are you going to document your advice in protest, as we like to say, or are you going to have a policy or practice within your service that you never document in protest, right, when you know the advice isn't going to be taken? These, again, are questions that are better to sort out as a system leading, this, or as collectively, if you have multiple healthcare ethics committees across your system, better to agree on this across organization or across the various hospitals within the system than to kind of handle it piecemeal as well. Yes, how are you going to? Yes, the shadow chart, and how would your risk managers and lawyers feel if they knew you had one, right? I think that's a wonderful question. I don't know that there's a agreed upon answer. I think ultimately, right, I think this is part of why, unfortunately, right, it's sad in part that this is something that we have to talk about at the level of building and leading a systemic ethics program, as opposed to, hey, here are the national standards. Right. But I think you and I both know, we all probably know who have followed the literature, right? There is actually no agreement on whether or not an ethics chart note ought to be totally transparent and intelligible to all of the stakeholders who legitimately have access to it, right? Should it make perfect sense? Should anybody be able to read it and understand what happened, right? Should anybody who was directly involved be able to read the chart note and understand what happened, right? Different people do different things. And because there is not a national standard agreed upon, uniformly implemented across the United States, let alone any other jurisdiction, it falls to systemic leadership, right? Or systemic cooperation among healthcare ethics committees when they're the ones handling consults to decide how they're going to proceed and do it thoughtfully, right? It's a lot to take on, but it's kind of important. Next slide, though. I would love to engage with that question more. I think we could do a whole other presentation. My slides. Oh, you have one.
So yeah, and I just bouncing off of that, thinking about like duty to who, right? Like what is the chart note purpose? Who is it serving? Is it serving the patient? Is it serving the healthcare team? Is it serving the hospital system? Just some things to consider. So, right, we always want to be cognizant that the EMR is a legal document, right, that can be used in a legal case and has been. Also our rhetoric, right, when we're writing the notes, the language we're using, what are we reifying, things that, which is why I know it saves everyone time, but the whole like copy and paste situation that is so persistent in medical care, right? You're just sort of reifying language over and over and over again without sort of assessing whether the language is appropriate for patients and the stories. And thinking about like how our charting is shaping perceived stories of these patients, right? It's our perception of what the patient is going through. The patient is not writing their own note. So just being really cognizant of the way that we're shaping perceptions of their character, of their narrative, and their life, and sort of asking what absolutely has to be part of a note, right? We're at 3 o'clock, so I'm just going to sort of speed through this. Just sort of, we've talked a lot about ethics being part of decision making, and the slides are going to be available, I think, right? So you can go through them. Yes, yep, the slides will be available afterwards in some way, I'm being told. Yes. What was the outcome of this case is that he ended up going home with trach support. Home meaning his house in the States. Yep, in the States, with home health and some other services coming to offer training about the management of a trach at home by the family. Yes. No, he had all his family was living here. Yep. Yeah, there was, we don't have time to go into particularities, unfortunately, but there was a lot of dynamics because it was a multi-generational home and there was really no place to put a hospital bed. And there was all these dynamics that we faced to try and make the best preferences for the patient and his family. But yes, that's how that resolved. Great question. Not that I'm aware of. But he has not died either. So we'll see. Anyway, to be continued. So thinking about sort of these are just differences, right, in terms of the case, right? There was both clinical ethics bedside dilemmas and also organizational ethics issues in one case that were certainly in a lot of ways competing with one another and sort of conflicting. So I'll let you guys read those when you get the slides. But do we want to go over this? Yeah.
We do have a wonderful biblical wrap up for you, but before we do, right, I think we can all attest. This was 2 hours and we barely scratched the surface, which we apologize for, but it's kind of necessity, right? We talked about, one of the reasons I think amply illustrated one of the reasons it's vitally important to have some systemic collaboration around consultation and around consultation standards. You all have mentioned policy and procedure, right? And you will have seen blazing, and that sounds like it's an important part of the work you all do on part of your ethics committees as well, right? One thing I would, certainly, one of the things we haven't talked about and don't really have time to talk about today, but are things also that benefit in our experience from a systematized approach with it, or is ethics education, right? If you're not already collaborating across your hospitals and across your various hospitals ethics committees on at least, some sort of unified educational event that brings, we would, from our own experience, would urge that in the strongest terms. It brings people together. It gives folks the chance to network within your systems, much as you all are doing across systems right now. And it really does energize people, right? It counterintuitive. My fear every year that we put on our annual education event at our last place, right, was that people were going to begrudge us the half day or the whole day, and wonder why they'd taken time away from the clinic, and even in some cases taken time off, paid time off in order to be there. People reliably were grateful that they were able to get together across all the different care sites, at least for one day a year, to compare notes, and to be reassured that none of us were in this alone. Another thing too that I would be remiss if I didn't mention, we feel like we would be remiss if we didn't mention in terms of systemic engagements, that healthcare ethics committees really have to be proactive about if they're going to be engaged with, at least in our experience, is emergency preparedness. I'm not going to ask for a show of hands because your lawyers would all cringe if I did, but I'm not going to ask how many ethics committees in this room were involved directly in drawing up COVID-19 patient triage guidelines for your organizations. I have some people who are volunteering. The risk managers be darned. It's in all seriousness, right? But I can tell you, right, from comparing notes across different healthcare systems, we know that wasn't a uniform thing, right? Ultimately, some organizations thought to consult their ethics mechanisms, some did not. The only way to be sure, right, is if your organizations are alert to the fact that the ethics committee recognizes the human elements in these decisions and expects to be involved. And ultimately, right, the inclination is to treat that as a once in a lifetime thing, right? We hope very much that it's a once in a lifetime thing, this COVID-19. But the fact is, patient triage and resource scarcity decisions arise every year, right? It takes different forms. Again, organizations it doesn't necessarily occur to them to involve the Healthcare Ethics Committee unless the Healthcare Ethics Committee or the other ethics mechanism is active in asserting that, yes, these are human decisions that at least need some guidance and review. This year, for example, right now, it's the shortage of cisplatin and carboplatin, and decisions about, for some systems, about which patients continue to receive the therapy as ordered and which don't. 4 years ago, it was a shortage of TPN that threatened to result in some home health patients not having life-sustaining nutrition, right? These things come up year in, year out. The COVID-19 was especially egregious, right? But it's not actually that strange that these human decisions would come up. And that's to say nothing of the ways in which healthcare ethics committees and ethics mechanisms might reasonably want to interface with external stakeholders, all in ways that require, engagement, not just in terms of the cases that get in front of us, but really benefit from recognizing that there are broader organizational issues that could benefit from the involvement and advice of the ethics committee.
Whoop. So just to end, we're circling back to Nehemiah and the strategies, right, that he demonstrates that we can glean off. And I've just got these passages here. Let's just take a quick moment, like pull up your phone if you can. Just sort of split. Maybe someone do 1, someone do 2, someone do 3. And we're pulling from here sort of his process, right, of both the request and the recruitment and pitch, and some of the resistance that he faced, right? And what are things that we can glean from his experience and that process that very much resonates with building an ethics program at an organization. I'm apologizing to this group that just did one. That's supposed to be chapter 2, 4, and 8. Sorry. Sorry. I'm like listening to the passage, like, wait. Okay. That was kind of quick. I'm sorry. Especially with the error. So for those of you that had the request from Nehemiah, which should have been Nehemiah 2, 4 to 8, what are some things that came out for you? Yeah, so like thinking ahead, right, of what are the things we're going to need to implement and make this happen, and being able to have that formulated at the time of a request, right? Did anyone else have number 1? No? Okay. Who did 2, the recruitment and pitch? Anybody? I think everybody was going through the whole list then. The whole thing. Okay, you guys did 3. Talk to me about that. That's a great takeaway. And another piece to that, right, is sort of the way in which the wall was being perceived by the communities, right, as a threat, right? So in what ways can building an ethics program actually maybe make some people unhappy, right? It's going against the flow, as we saw this morning, right, with accompaniment, right? Like it's against culture sometimes, what we're recommending, what we're doing in an organization. So what kind of resistance we could sort of expect to face. So a lot of this has already been mentioned, and we don't have time to really go through it, but thinking about the relational equity, right? Like the relationship with the king, I think one of the things that come out to me for this story is he was a cupbearer, right? Like not very high on the totem pole. And for the king to have noticed his facial expression and asked, right? There was some relational equity that had been established. Powerful, powerful stuff. And sort of the investment we are called to do, right, with everyone that we come encounter with in ethics. That's what we do. And then building and battling. This is like later on in the story, right, when they're going through the oppression and resistance. So there was this time, right, where part of them were working as constructors while the other part of them were holding spears, right, ready for battle. And I think that is a lot of times the work of ethics, right? We are at times building and operating sort of operational pieces, but also putting out fires and feeling like we're sort of picking battles that are worth being picked in some ways. And it feels like we're going against the grain, right? And it feels like a battle sometimes. There's a dual work there that ethics does. And then this is the part that I love the most, right? A gathering place. And he says this sort of multiple times in the passage, but in 1:9, he says, I will gather from there and bring them to the chosen dwelling. This is a promise that God had given to Israel. And then the work is great, extensive. This is Nehemiah. The work is great, extensive, and we are separated from one another. Rally to us here. So thinking about how all of us in different sites, in different hospitals, right, can really gather together under the umbrella and sort of the mission of ethics in each of our organizations, and be a support to one another. And I think that's what ethics, organizational ethics and ethics programs can be and have the potential to be, right? Is sort of this dwelling place in which we all come together. So thank you so much. I don't know if we've got 2 minutes for questions.
Yeah. So yes, under cover of changing one word in the previous version, they've slipped it back in, effective at the end of this year. So that I mean, that's good. So on the one hand, yes, that's good news. Yes, once again, their organizations are expected if you're accredited by the Joint Commission, which I appreciate. Not everyone is, right? But if you're accredited, you're expected to have a mechanism for resolving ethical disputes in healthcare. But let's be honest, right? Lots of organizations have satisfied that requirement by having a healthcare ethics committee that meets on paper, and only shows up maybe once a year or whatever else. Obviously none of the ones represented in this room, which is fantastic. And my point is, that's not why any of us were actually doing this, and it's not why any of our organizations were actually supporting it. I hope, right? Because that is extremely shaky ground to hope that the Joint Commission continues to show us favor. That said, even if it were, right, most of the responsibilities that would apply, the standards of performance and rights and responsibilities in the individual, would be challenging to meet without a well-functioning ethics committee. It wouldn't be impossible. Some places do, but it would be difficult. And famously, a lot of the elective certifications that hospitals increasingly pursue, for example, magnet certification for their nurses, are frankly impossible to satisfy without a well-functioning interdisciplinary ethics committee. But yeah, great comment. That's a great question. I think in terms of that, I think that's what's interesting, right? Is that have we between the two of us developed an explicit organizational ethics committee that that has a separate membership, a separate roster, separate charter from a bioethics committee? I have not. I don't know. However, right, what I will say, right, is that and part of we didn't rehash or quote from them at length, but there are a couple of resources in the list of resources that get to this point. While healthcare ethics committees are not necessarily the best suited to police, they're almost certainly not the best suited to police every single organizational ethics issue. A shocking amount, if ethics committees have the appetite, does tumble over into it, right? And that's part of actually why we chose the case we did, is that this case not only raises issues for this particular patient, right, but ultimately, if the organization is committed to being fair about how they apportion, say, charity care, right, or things like this, these are the sorts of things that healthcare ethics committees need to commit to advising on, and frequently may need to commit to being involved in decisions about fundamental organizational ethical issues. I think I would be very interested to hear from you. I regret we don't have necessarily time, but we can certainly talk after if you yourself have experience developing a separate organizational ethics committee with different roster charter in progress. And I would love to hear from you, and I imagine others would as well. But what I will say, though, is that even in organizations, I'm not to say that this is true of any of the organizations I've been associated with, but supposing that the organization had entrenched stakeholders that were not interested in seeing a separate committee over reviewing, say, business decisions, right? There are nevertheless a lot of ways in which a well-functioning ethics committee can help ensure that, at least insofar as it affects patients and families, the healthcare organization's business decisions line up with its stated values.
Yeah, and I'll just add that I think, right, we had that phrase like ethics is everyone's business, I think was the phrase, but I think that part of what's challenging is creating boundaries that are sustainable, right, for the work that we do. It's usually a lot of us, right, are not doing ethics full time, right? We have other responsibilities in addition to ethics. And I think based on the models that we surveyed in the room, that was true of most of you here. So thinking about like what teams in terms of infrastructure would be able to sort of create a separate program like that. I think what I have found a little bit more maybe attainable in the program that I'm at now is that there's already a structure in place more or less to tailor to leadership administration and sort of mentorship and coaching for administration. And we can plug into that without having to sort of create a new program altogether. And they've been receptive to that. So I think creating that relational equity, back to Nehemiah, we can really do a lot with that. Yeah. Thank you so much for having us. Appreciate it.